that.
Yeah.
Is that all right now?
Yes.
Okay. So I have here my tools for a lasting filter. As we all know that trabeculectomy is a surgery against nature, where in all other surgeries we pray for healing. Here we pray for not healing. So it's a completely different ball game from any other surgery that we do. So these are the tools I thought would go a long way in achieving that target. So trabeculectomy is an excellent procedure when it succeeds. To ensure it does, you've got to avoid many landmines along the way, like conjunctival buttonholes, over and under filtration, and hemorrhage. Over the years, we've seen that surgeons do well, but could do better when performing this procedure. With two key factors for a lasting filter, these are what I have designed using mitomycin C as an adjunctive. I call this the Paul conjunctival separator. The manufacturer has it as the PCS. And this is the Paul scleral scissors, the PSS, that's designing a special kind of scleral scissors for the flap. So I have no financial interest here, but preoperatively, I instill a drop of brimonidine into the conjunctival sac. It actually acts as a vasoconstrictor and actually helps me in showing my way through the surgery. So these are small clips from the surgery. That's the Weck cell dissection, where we make sure that the conjunctiva is freely mobile over that area, superior part of the globe. And we use completely non-tooth forceps, blunt forceps, and that's the raising the conjunctiva. I usually do a fornix-based incision, but it has been proved beyond doubt in literature that any fornix-based or limbus-based, it depends on what you are comfortable with. The adjunctive use of MMC has been a major advance in the post-trabeculectomy titration of intraocular pressure and in maintaining the patency of the ostium by its antifibrotic activity. Protocols for adjunctive therapy that allow an acceptable balance between the risk and the benefits. That's the reason I actually thought of designing this, because this has a length of about 125 millimeters, a head diameter of about, say, 5 millimeters, and it has a length of another 5 millimeters, and the neck that you see out here is about 30 degrees bent, and it has a steel handle. So now how do I use it and how do we benefit from it? So here it is in the surgery. So as you all know, mitomycin application is a completely non-touch technique that we follow. It should not touch the conjunctiva at all. So this is how I generally use it. I use that and to lift up the conjunctiva, and then I actually tuck in the sponge containing the mitomycin C right in posteriorly, so that it goes as posteriorly as possible without touching the conjunctiva. It's a very simple instrument, but goes a long way in the treatment of the surgery. And that's it. And then you wash it off. Next comes the Paul scleral scissors. This is actually a titanium normal scissor, which is very similar to a vitreous scissor. I designed it in 17 gauge titanium. The overall length is 150 millimeters. The blade length that's here, it's 2.3 and has a 20-degree bend, which allows for easy insertion through the scleral pocket. I'll show you that surgery in a moment's time. And the contour to the profile of the globe safely cuts the sides of the scleral pocket. The tip is rounded, allowing the instrument to be used as a pickup to lift up the tissue and cause minimal risk to the underlying tissue. And this is, I generally design my scleral flaps 3 millimeters by 2.5 millimeters, and that's the surgery out here, if you look at it. So what happens is that when you, this is almost like SICS that I make a pocket. It's close. It's something like the Morphil safe surgery technique of trabeculectomy. And that's the scissor that I use. And because the blades are 2.5, they fall short, and I cut them actually, say 2.3, and I don't go up to the limbus, so that it helps in directing the aqueous backwards over a wider area, encouraging a greater posterior flow and a more diffuse bleb. And then this is the punching out of the ostium. That's the normal Kelly's punch, which we all use to punch out the ostium. And following that, is the iridectomy, which is also a routine procedure which is carried out whenever we do trabeculectomy. And then we come to the releasable sutures. I generally almost always use releasable sutures because it helps you to tighten the intraocular pressure post-operatively. And with the use of mitomycin, you can actually tighten that releasable suture right up to 3 to 4 weeks because it's possible to do it. But without mitomycin, that suture actually, it's almost just about 2 weeks that you can tighten the intraocular pressure. So that's the releasable suture with the 4 throws that you see out there. And following this is the closure of the wound. That's a normal closure that generally is done with 9O nylon. And apart from that, the scissors also used in phacotrabeculectomy. So what I do is that I do a flap superiorly and then make the same incision and cut the flap, and then I just extend my hand a little bit on the right side, and I do the phaco. So you would see that's the trabeculectomy flap, and that's the phaco just entering on the side. And you can complete your phaco with your capsular excess and your phacoemulsification. And once you've finished off with your phacoemulsification, you can just go back and you can complete your trabeculectomy. So per-operative surgical pearls are injection mannitol 20%. I use it just before surgery, 100 ml. And consider topical or bulbar anesthesia. Never use tooth forceps to handle the conjunctiva. Aim for watertight conjunctival closure. Low, high preoperative IOP is desirable, and never leave the operating room with an unclosed leak. So technical modifications to the trabeculectomy combined with the use of applying powerful antimetabolites enable the surgeon to have much greater control of both the operation and the post-operative scarring. The safer surgery systems development is based on the need to improve consistency. Trabeculectomy with MMC is a complex surgery requiring a great degree of manual dexterity and extensive glaucoma experience. But I encourage those of you in the audience who do perform glaucoma surgery to regard trabeculectomy as your initial choice and the gold standard for the first surgical treatment of glaucoma. And that's the team who actually put up with all the acrobatics that goes on in my theater. Thank you very much.